So now, trying to keep to time, I'd like to invite members of the audience to ask questions to our panel. There are 2 microphones set up, one here, one there. If you would like to form an orderly queue, that would be very helpful. And if you could identify, yeah, up you go then, Alan. Form an orderly queue after Alan Hudson, and please say who you are and to whom your question is directed, or if it's to the whole of the panel, to the whole of the panel, and we'll see how we get on. So, good. I've got 2 lined up, and I'm going to go that way, that way, that way, that way. So I hope I'm going to get some more. So over to you, Alan.
Okay, so I've got the microphone first because it's next to my seat. But I've got a comment and a query about latent parasite infections, which Diane highlighted was a problem. And I think there's some real parallels here with the cancer area, where you get quiescent tumour cells, which are very difficult to treat. And these are formed by the hypoxic conditions which develop inside tumour cells. And I just wonder how many of the latent parasite forms which we have problems with are actually being formed under hypoxic conditions. In the tumour area, what you see there is you get various enzyme levels going up, such as DT diopherases. And again, I wonder if in the cellular environment which these parasites live, whether anybody's ever looked at that to see if these enzymes are going up.
Okay.
If you want to treat a quiescent parasite, a tumour cell, you need a very reactive compound. If you have a very reactive compound, you'll get toxicity. So the drugs which they're trying in the cancer area, and which I think we've got in the parasite area, rely on their activity by being generated in the tissue or the cellular environment where the parasites are living. And I think if we look at some compounds which could work that way, we have the classic example of primaquine, which works against hypnozoites in malaria. And that is almost certainly generating the radicals which kill the parasites. The other examples would be the nitroheterocycles, which again are being reduced by the parasites. So my question is anybody ever looked at what causes quiescence in the parasites in the different diseases we're interested in?
I think it's a great question. I know the literature from Plasmodium vivax fairly well, and that doesn't seem to be a big factor in Plasmodium vivax. For T. cruzi, there may be someone else on the panel, Jim is nodding his head, that knows it. But I think it's a very good point that we just don't understand what drives the organism into latency or chronicity. And we actually, in many cases, don't know whether it's latency or it's just very slow turnover, in the form of chronicity. And those may be quite different biologically. So I don't know, does anyone else want to answer,
Well, would you like
Alan?
to comment on the hypnozoite? I mean, is that not a quiescent
Hypnozoite looks like it's completely quiescent, and I think it's very interesting. I hadn't thought about, obviously primaquine is one of the few drugs that gives you radical cure over a very long treatment phase, and that may very well be the key mechanism. I think the alternative strategy, which I tried to emphasize, is not so much targeting the organism, which I think is going to be quite difficult, but to target the cell that's carrying the organism in some way which makes it inhospitable for the organism to remain. The cell that contains a latent organism must be in some way at least sort of allowing that to happen. So I think that's another area which is, as far as I know, virtually unexplored.
Yeah, and do trypanosomes have HIF1 alpha?
Yeah, right.
They do they?
Yeah.
They do. So they have the prolyl hydroxylase, which is found in the tumour cells that regulates the behaviour of the cancer cell. There you go. Somebody else had their hand up? Yeah, Gerald, and then we'll move to a question over there.
It was just a general comment, which I wouldn't comment on the parasites, of course, but on the cells. And also one thing that has been missing so far is really tools to map and basically delineate the oxygen concentrations. In tissues, it's not so difficult, but inside cells and inside cell compartments. So this is, again, where science is important. And there is a whole area of development now of smart probes, phosphorescence-based probes, for instance, not fluorescence, which are able to look at the decay of under certain wavelengths. And you can basically map in subcellular conditions the concentration of oxygen. So again, these are generic areas which are essential to develop.
Okay, last comment.
Right. I think the persistence in terms of Lashmania is quite different because it seems to be regulated by the immune system. So there's really, on one hand, that of course an ongoing immune response, Th1, is actually controlling the parasite level. And on the other hand, parasite induces IL-10 in order to survive. So there's a really very delicate balance. So I think that we have in Lashmania always truly cell-cycling parasites, and if you actually inhibit the Th1 response, they just come up again.
Right, okay, thank you very much. So you've been very patient, Els. Would you introduce yourself and ask a question?
My name is Els Torela. I have a long history at DNDi, so I'm not going to dwell on that. Several of you have made a very eloquent point in showing how much more knowledge we have about the parasites, the genomes, the molecules, the targets, etc. And it's been a great advance compared to 15 years ago. But I want to bring that back also to what we've heard from Michel Kazatchkin this morning about the fact that we're actually talking about neglected people, and that the numbers of neglected people with the inequality rising rather than going down, despite more countries that, based on their GDP, are kind of considered now middle-income countries or high-income countries. If we think about the neglected people, they have multiple diseases. They suffer from sometimes parasitic diseases, viral diseases, etc. And I'm just wondering, instead of going deeper and deeper into each disease and thinking we will have the magic bullet for this one disease and then another disease and another disease, all these different magic bullets, are there opportunities with all the knowledge that we are creating to think a little bit more holistically about developing drugs that actually are not even pan-genotypic or pan-kinetoplastic, but thinking actually much more about treating patients that have multiple diseases and thinking a little bit less specific and much more broad spectrum. And I want to refer, you will not be surprised, to fexinizole, which we started working on as a treatment for sleeping sickness, but turns out we knew that already from the beginning, that it has broad spectrum potential. And actually, it's a fantastically powerful idea that we can have one drug that cures multiple diseases. And is there in the new technologies ways in we can take that a step further?
Whoa, that's a big question. Who wants to have a go at that one?
We'll leave that to the chair.
Oh, you leave it to the chair. Okay, well, neglected diseases are extremely complex, and I don't think a single intervention strategy will ever solve this. We need multiple points of attack. We need to be able to prevent the parasites getting into us in the first place. So insecticide-treated bed nets is a really good example of a cost-effective intervention. It doesn't solve it all, but it's good. Then you want vaccines where possible. Again, I'll have to pick malaria because we don't have them for the canetoplastids at the moment, to prevent the infection taking hold. Then we need drugs to get them out of us once we have them in, and if they're broad spectrum and they can have multiple indications, that's fantastic. Think about the development costs you'll save if fexinizole works against all canetoplastids. Wonderful. Then we need, very importantly, public health measures to control the vectors, whether they're insects or snails, and we need education of people living in disease-endemic countries. And I think educating children who then go back to tell their mothers what they've learned about hygiene and so on, and the causes of disease are really important. Now, I don't want to get into a complex lecture on all these different aspects. There are many more, you know, smoke pollution, adequate nutrition, access is very important. I'm a great supporter of equitable access for medicines. So I could go on else, but this is a huge political debate which I'll maybe continue with you over lunch or something. Okay, you have another thought?
Just one very quick comment. I think the way sort of drug development and intervention disease is developing is actually more and more specificity, because we realize that diseases, even, you know, diseases like prostate cancer or breast cancer, are really a spectrum of diseases. And in fact, that's this whole question of, you know, using genomes to identify when drugs will work. I think neglected diseases need that same kind of laser focus to knock out the disease. And, you know, yes, it's a big, you know, it's a big trip. It's a lot of work. But on the other hand, look what's happened. I mean, look what's happened just by focusing on malaria or focusing on lymphatic filariasis with current tools. So I would argue this is the way to go. It's intellectually interesting to have a pan drug that could cure everything, but I think science is telling us that's probably not going to work.
And just very quickly to your point, the holistic piece, if you take the HIV field, was to have drugs for HIV that you could also give with TB drugs or pneumocystis or CMV and so on. So I think there is that for the neglected individuals. There is a holistic piece about how you put the medicines together.
And I'll just make a brief comment that certainly one of the things that's missing now in the research community that we ought to see in the next decade is a better understanding of the biology of multiple infections. Because I will say, when I put on my doctor hat and I talk about seeing kids in Sudan or Nepal, when those kids come, they don't just have malaria, they have worms, and they probably have something else, right? And so what happens if a kid first gets an intestinal helminth and then gets malaria? Or what happens if a kid first gets malaria and then gets schistosomiasis? What is the effect of one disease on another? We don't know, okay? And until we know that, it's going to be very difficult to try to think about even coming up with something that's pan-disease.
Thank you. Farouk, you've been very patient there. Would you like to identify yourself in full and ask a question, please?
Thank you. My name is Farouk Modaber. I've been around for quite some time, so I think I don't think I have to talk about that too long. We were late for lunch. So first of all, I was delighted to hear Diane mentioning that the immune response is important and that drug development cannot only focus on killing the parasite, that in fact we have to consider the host. And I think in drug development in general, and also it was mentioned by others, that of course to develop a drug to kill the parasite is very important. But I think the HIV field taught us a lot about having a potent drug to kill the parasite, but then if you stop treatment, and in fact patients cure with leishmaniasis, for example, with ambisome, then in fact the parasite comes back, the infection comes back. So what in fact keeps the parasite in control is the immune response, and we have to consider that. Secondly, if you look at mucosal leishmaniasis, there's hardly any leishmania actually in the mucosal lesion. But nevertheless, because a wrong immune response, as was mentioned, was triggered, the pathology continues. So some of our diseases, in fact, have immunological basis for the pathology that they develop. So having said all these things, and in fact, that would be one factor that would be across the board for different diseases, looking at the immune responses and trying to trigger or modify the immune responses that are already there. And I really appreciate that comment. There's only one other question that I had, actually, was from Diane again. You know, there's a confusion about speciation in Leishmania. You have what used to be very simple Leishmania tropica and Leishmania major. Now you have genetic markers that are one type, like Leishmania major, or Leishmania tropica especially, but in fact, the bug behaves like Leishmania major. And I was wondering, in your screening, which I think for your purpose, there won't be any problem because you're actually looking at the gene that you have displaced. But in general, would post-translational modification pose an important question in setting that kind of a screening system for new drugs? Thank you.
You know, I think a very important thing to keep in mind, you raise a very important issue, and that is this question of, you know, what does it mean if organisms are genetically different? Does that relate then to their disease pathogenesis? And there are others on the panel that may want to comment on this, but what I think is important to think about here is, you know, what are the drivers of differences in pathogenesis that are genetically or epigenetically determined? And I really think, with a couple of exceptions, that we're at a very early stage in that kind of analysis. And in fact, in Plasmodium falciparum, it's clear that genetic background of the parasite makes a difference to response to drugs. Now, whether that's going to make a difference in the therapeutic use of these drugs is not clear. But so I think it's an area where we're just beginning to touch on the knowledge. And you raise, I think, a very important issue, one that is worth kind of looking at systematically. And we have the tools to do it, and I think it's just a question of sort of getting the community to think about it a little bit more broadly. Not every parasite that's labeled Leishmania is actually the same organism. And I think that's an evolution that's happened in Plasmodium, and I expect it'll happen in the others.
Okay, thank you. I'm conscious of the time that we started 15 minutes late. We've clawed back some time, but lunch is not all that long, and I'm sure that there are other questions that could be asked directly to the panelists over lunch. And what I'd just like to say is that we do have a future vision, we do have a future strategy in early stage drug discovery, and it's very encouraging, and I hope that these new directions are successful. So with that, I'd just like you to thank our speaker and our panel of experts, and wish you bon appetit.